Hey guys, my name is Sergio, and my sentinel event is alarm fatigue, a preventable event. The scenario: in 2008, LA, a 60-year-old man was admitted to the UMass Memorial Medical Center due to a tree trimming accident that resulted in facial bone fractures and brain bleeds. He required immediate surgical intervention, which he did receive, and was then sent to the ICU to recover. During his stay in the ICU, he appeared restless, disengaging from the monitors and triggering their alarms. He was then medicated with a benzodiazepine to relax him. A medication administration error was done here, in which they actually dosed him with a higher concentration of benzos than was actually in his MAR. Such error may or may not have contributed to what happened next. An hour after administration of the benzodiazepine, Ellie's alarms began to go off, signaling that he was tachycardic, tachypneic, and had a low O2 saturation. No nurses came to his room for another hour, either due to them assuming that it was just another false alarm, or being overwhelmed by the potential noises that are common in the ICU. Either way, they came in only after a more serious alarm went off, which indicated he was dyspneic. A code blue was called, CPR was performed, and he was able to be brought back and put on a ventilator. He suffered severe brain damage as a result, and his family decided to withdraw him from life support. He would die soon after. To better understand what happened, a root cause analysis, which is a process that breaks down all the factors that led to a particular consequence, can be done, utilizing both the fishbone analysis and a SWOT analysis. In the fishbone, we can break down the events into four separate categories: protocol policy, staff, environment, and equipment. Subcategories under protocol policies include excess charting, alarm configuration, lack of supervision, and lack of refresher training. Nurses are required to chart everything they do and observe, which prevents them from spending more time with their patients. If it isn't charted, then it didn't happen. Alarm configurations are also not always personalized, causing alarms to go off more often than they should. Nurses also may forget specific rules, and when not reinforced by trainings or supervisors, then certain policies begin to break down. Under staff, we have decreased staffing, different nursing skill levels, and patient ratios. Due to nursing shortages, nurses are overworked, given larger ratios, and are unable to provide the care they are capable of. To help aid this, new nurses are hired. However, lack of experience makes them unable to respond as well as a seasoned nurse. For the environment, we have the ICU, increased stress, multiple alarms, and unit floor plan. The ICU is a very stressful environment where patients are in critical condition. Multiple alarms going off from all directions makes it difficult to know which patient to address first, and it allows a nurse to adjust and ignore noises. The floor plan may also make it difficult to go to one patient if, for example, the med cart is on the other side of the floor. Under equipment, we have faulty equipment, overuse of equipment, and different brands. Due to the amount of alarms that already go off, it is vital to prevent any more unnecessary noise, which is why it is vital that equipment does not fall off. Also, equipment should be used on an as-needed basis. Not all patients require the same level of monitoring. By also sticking to one brand, nurses may be able to better adjust to the sounds and better know how to utilize the equipment effectively. All these factors ultimately lead to alarm fatigue, causing decreased care, resulting in severe patient injury and death. In the SWOT analysis, factors are broken down as internal or external and whether they are helpful or harmful as shown in the chart. For strengths, we have that the alarms were effective in notifying of any changes outside of the parameters. Nurses, although failing to respond to the initial alarms, responded immediately to the more severe alarms, which also showed that alarms were functioning. For weaknesses, we have that most devices have only one type of alarm sound, meaning that it does not differentiate between severity of condition. There are also multiple sources of alarms. There was an assumption that a different hospital personnel would address the alarm. Delayed intervention resulted in patient death, and there was a lack of communication between personnel. On the external side of things, under opportunities, policies can be reinforced, education can be increased to increase competency, and policies can be updated to make them more functional and effective. Under threats, there are the default settings on equipment, overuse of said equipment, nurse overstimulation, lack of staffing, increased nursing responsibilities, increasing stress, and the lawsuits, which resulted in a loss of hundreds of thousands of dollars. After analyzing the fatal event and determining all of its contributing factors, it is evident that healthcare workers are becoming desensitized to hospital alarms due to the increased number of alarm sounds, resulting in decreased response times. The proposed solution is the implementation of a specialized training program regarding alarm management and effects of alarm fatigue in patient care. The objective is to have a 20% reduction in the length of time it takes a nurse to intervene to a patient's alarm in the first year. Stakeholders include nurses, CNAs, nursing administration, and educators, as well as patients. It is expected that nurses will handle change very well, as their profession is very dynamic and is constantly changing due to research and innovation. However, they may feel education is not what is needed regarding alarms, and as such, may take some convincing to address such issues. They are also the population who will partake in the intervention, and so their support will help aid in streamlining the process of beginning the change. CNAs may provide additional surveillance for alarms, as they are on the floors and are an effective aid for nurses. Collaboration between both professions is essential for improved patient care. When both professions are effective collaborators, patient care improves. Nurse administration and educators may act as facilitators and serve as additional resources as well as connectors. Their involvement is essential so that the program can be implemented faster and more smoothly. Patients are also important stakeholders, as they are the actual population that are going to be directly impacted by the changes, and so increased support from that population may actually help convince the aforementioned professions to support the proposed intervention. For resources, we can divide it into three separate sections: physical, human, and financial. For physical, we need a location. However, hospitals tend to already have a room for trainings, and as such, no additional location will be required. Printing material for testing and educational purposes will also be utilized. For the human section, we will need in-person instructors to provide the training to the charge nurses. Charge nurses will also be a part of this, as they will then have to relay the training to the nurses in the units. For financial, additional pay for charge nurse trainings will be required. They will have a 2-hour additional pay on top of the regular schedule. For the nurse staff trainings, they will need an additional 30-minute pay on top of the regular work schedule. And for the in-person instructor who will be training the charge nurses, they will be paid between $8,000 and $10,000 per training cycle. Since there will be a total of 3 training cycles per year, $24,000 to $30,000 will be needed for in-person instructors alone. To effectively implement the new program, Lewis's change model would be utilized. This model is simple and has been effectively utilized numerous times in quality improvement projects across various nursing specialty areas. It is divided into 3 distinct steps: unfreezing, changing, and refreezing. The unfreezing phase is the most crucial and involves increasing awareness and talking about the causes of the problem. Demonstrating how implementation of a new training program is effective will increase willingness to change. Any concerns by nursing personnel would be addressed as well. In the changing phase, ideas to address the problem as well as the length of the training would be discussed to provide nurses all the necessary information before implementation. The last phase, known as the refreezing phase, occurs when the new plan is implemented and reinforced so as to become the new status quo. It is vital to monitor every step to ensure that systemic change occurs. The initiation of the intervention's implementation timeline would first start with a notification that the change will occur 6 weeks in advance during huddles. This information would be relayed every shift until the start of the training. A full description will be available in the break rooms, and emails will be sent weekly. 4 weeks prior to the intervention, sign-up sheets will be available for the particular dates in which nurses can partake in the trainings. There will be 3 different 20-minute trainings that nurses must sign up for. The trainings will take place during huddles, and nurses are required to arrive 10 minutes earlier than their regular shift to allot enough time to complete their 20-minute sessions. Charge nurses will also have their own sign-up sheets, but such trainings will not occur during their shift to provide them enough time to be able to train the nurses in their unit. 1 week prior to the general training, charge nurses will complete their 2 one-hour sessions. A week after the charge nurses are trained, nursing staff trainings will begin. If a nurse works a shift that has training scheduled for the day, they must partake in the training regardless of whether they have already done that particular training. There will be a total of 3 separate training cycles in a year: for a recurrence rate of 4 months. Each training will be refined using prior nurse feedback and may be individualized to each unit focusing on their particular deficits. An evaluation plan is needed to be able to know if the intervention has been effective. Using the Kirkpatrick model, which is a 4-level evaluation model widely accepted as a framework for examination of results since the late 1950s, one is able to understand if there is a problem with the intervention and if so, what parts of the interventions are failing. The first level is called reaction, and it is evaluating by asking the nurse how they felt about the 20-minute sessions, the content, and the delivery of the training which was given by the charge nurse. This is valuable as it would aid in preparing the next sessions and allow each training to be more specialized to what the unit is lacking. The next level is called learning. A pre and post test consisting of 15 questions is to be given immediately prior and after the training, serving as a method for understanding, improvement, and retention. The third level is called job performance. A record of response times prior to the implementation of the intervention will serve as a baseline to compare the new response times. This will show if the new trainings were effective and would be done 3 months after implementation so as to allow the nurses to adapt to the new changes and serve as an accurate representation of the training program. The fourth level of evaluation is the organizational impact. This level would include the number of incidents, the severity, such as the additional hospital stays a patient had, as well as deaths. It would also include the cost prior and after the intervention to compare if there was a price reduction due to the better care nurses would be providing, and would be done 6 months and 12 months after the initial training started. For the communication plan, charge nurses will give a report at the end of the month during huddle, which will include stats for the month and new goals so that they continue to improve. Each report will include the average response time to alarms between shifts as well as the response time for the unit as a whole. It will also include injuries that resulted from delayed care and be divided as minor, severe, and fatal. All information will also be given via email. A large whiteboard will be displayed in the nurse's station with the same information to increase transparency. Every year, about 251,000 people die as a direct result of medical errors. Delayed treatment due to alarm fatigue should not be one of those errors. With continuous assessments, root cause analyses, and quality improvement plans, many more lives can be saved, and LA story can be prevented from ever being repeated. These are my references.